Welcome, everyone. Greetings for whatever time of the day it is in your part of the world. I'm Gunjan Veda from the Movement for Community-Led Development from Toronto, and I will be co-facilitating today's call with Nellie Mecklenburg from the Institute of State Effectiveness. I see a lot of familiar names and faces here. So you probably know, those of you who've been with us on this journey know why today is a very special call. Today marks 1 year of us doing these COVID calls. In April last year, we started these calls because a group of organizations came together and we suddenly realized all of us were having the exact same problems, the same concerns. We were grappling with similar issues. And so we said, well, why not come together and see, A, to know we are not alone, B, to brainstorm ideas and solutions and co-create and learn from each other. That's how these calls started in April last year. We never thought they'll go on for a year. I think we started at just doing this one call where we would just get together, brainstorm, come up with something and move on. But since then, these calls have become platforms and spaces for us to share concerns, ideas, learn together, come up with issues, seek information, share information. And we're really grateful to each one of you who's been with us through this journey on these different calls. Year of Zoom calls for most of us. So I think by now, everyone pretty much knows the Zoom etiquette, but we want to avoid the noise. So make sure that you're muted, but we want to hear your voice. These calls are all about you and, all about all of us. So they are what we make of it. So the chat box is your best friend. Use it right now to introduce yourselves, but also as you listen to our speakers, as the discussion goes on, as you have ideas, questions, thoughts that come to mind, experiences to share, concerns, please put them into the chat box. We are always monitoring the chat box. We'll make sure that your concerns are shared out aloud and the questions are taken to the speakers as they come up. Also, there is a raise hand button. I am sharing my screen right now, so I probably can't see, but I know my colleagues are monitoring this. So basically, this is our call. Remember, this is our space. And so it is going to be as effective, as engaging, and as vibrant as we make it. So please continue to engage with us there. All right, so today's agenda. So today's agenda, we are specifically looking at mental health. So again, if you remember when we started out these calls, for those of you who were with us, we started by looking at immediate short-term problems. We had access issues. We started when the world had just started going into lockdowns, a reality that we had not lived with at all at the scale that it was happening. International borders had closed. And so our first few calls had really been about coming to terms with that, sharing how each of us is coping with it and coming up with new mechanisms to do so. Then we moved on to things like scenario planning because we realized this is not a short-term problem. The pandemic was not going to go away in a few weeks' time. So we started doing things like scenario planning. And then the world started moving towards a vaccine and all of us had doubts, questions, concerns. So we actually had a wonderful team from WHO join us last November. We had people from the People's Vaccine Campaign and other groups join us and share some of the, share what's happening around vaccine effectiveness and efficacy. And then last month, we finally transitioned into the space that we are in now when we said that it's been a year of the pandemic. We know that we now know that our world is never going to be what it was before the pandemic started. So we know that we have to think about long-term adaptations. We have to think of what's coming next and how do we prepare ourselves and how do we build forward better, right? And so last month, we transitioned into thinking about the long-term impact of the pandemic. And we asked all of you, what is it that we would like to address first? What's on everybody's mind? And the single thing that came up that every single person mentioned was mental health. And so here we are. We know that this has been a concern for all of us. And we are very happy that we were actually able to, once again, reach out to the WHO and get somebody here who would be able to share resources, share what is happening, and just have this conversation with us. So the agenda today is that we're going to have Dr. Fahmi Hanna, and I will introduce him shortly, from the World Health Organization. He's with us today. He's going to share a little bit about what's happening with mental health in this pandemic, and also the kind of resources that are available for all of us. We're going to have Emma from One to One Africa. Again, I'll introduce her shortly, but she's going to share about what kind of mental health issues and concerns that are emerging in the communities where they work in South Africa, but also with the community health workers and others. We're going to have a panel, we're going to have a discussion, so you're going to have time to ask questions, engage. And then, as usual, we are going to move into our breakout groups. We'll come back, discuss what happened in the breakout groups, and then we close. So a fairly simple agenda, but as you can see, a packed one. So without further ado, I would like to introduce our speaker for today, Dr. Fahmi Hanna. Dr. Fahmi Hanna is Technical Officer at the World Health Organization for Mental Health and Substance Abuse. He is also the co-chair of the Interagency Standing Committee Reference Group on Mental Health and Psychological Support in Emergency Settings. He is going to take us through a little bit of what's been happening in the world on mental health, but also something which I didn't know, and he told us when Nelly and I met with the preparation for this. The WHO actually, the Interagency Standing Committee, I believe, and the WHO, they have a number of resources in multiple languages. I know in the past we've talked about issues of translation and stuff, but they're actually available, and he's going to share them with us. So Dr. Fahmi, over to you, and I am going to put up your slides.
Please, thank you, Gunjan. Would be great if you put up the slides. In the meantime, you mentioned about the resources. I have shared through the chat function here a couple of links which include many of the resources that I'm going to present now, and the ones you kindly just mentioned.
1 second.
Okay.
Here we are. Can you see it now?
I think it's coming. If you can start it, please.
Yeah.
It's full screen. Brilliant. Looks great. Thank you, Gunjan. And Gunjan and colleagues really pressure to join you in the movement for community-led development, and inspiring to hear about this wonderful calls you have been having, and the work you are doing all at global level and at country level, and the impact you are able to reach. Thank you for prioritizing mental health and reaching out to WHO for a speaker. I'm working at WHO headquarters in Geneva. I work at the Department of Mental Health and Substance Use. I'm a psychiatrist by training, and I co-chair an interagency group which deal with mental health and psychosocial support within the humanitarian system, a coalition of United Nations, non-governmental organization, and Red Cross and Red Crescent movement, which have this group a mandate of developing material and supporting country level work on mental health and psychosocial support, specifically in humanitarian emergencies. Would be great if we go to the next slide, please. Thank you. Colleagues, even before COVID-19, the situation of community-based mental health services was really bad. It was like this gentleman here trying to carry a very heavy load and trying to go uphill. The amount of budget spent on community-based mental health services globally, or mental health in general, is less than 2% in most countries of the world of the health budget, which is not enough to deal with mental health even before COVID-19. In places like in African region, there are some countries which have one mental health professional even for more than 10 million people, in some countries even larger. There is one mental health professional for every 10,000 people around the world, but there is one people in need for mental health services out of almost every 4 of us. But COVID has came, and COVID has direct effect on mental health needs. In fact, we know that COVID infection itself would increase rates of depression, of anxiety, of post-traumatic stress disorder, and neurological manifestations in everyone who is affected by COVID, including in short term and in long term as well. People with pre-existing mental health conditions are actually having more severe COVID infection and high rate of COVID mortality compared to the rest of the population. Imagine someone with pre-existing mental health condition like depression affected by all the stressors in today's world. But also people are indirectly affected by the mental health impacts of COVID. Fear from having the virus or fear from loved one affected by the virus. The impact of physical distancing on people feeling socially isolated, specifically more vulnerable people, such as older adults. And loneliness is one of the predisposing factors for mental health condition. COVID-19 stigma when someone is infected. Health workers who are providing services in many countries are affected by stigma related to COVID, and stigma have a high cost on mental health. Colleagues, also, COVID is affecting economical situations in many countries and many communities. And we know very well that the impact on livelihoods actually and adversity actually is having a negative effect on mental health. Next, please. WHO last year, between June and August, assessed the impact of COVID-19 on mental, neurological, and substance use services. A very limited service of mental, neurological, and substance use services that we had in countries. The results was really remarkable. We knew that 93% of countries reported that at least one of their essential mental health services has been disrupted. Some of the life-saving services, such as opioid withdrawal management services, for example, 50% of them was disrupted. Countries were reporting like more than 65% of the school mental health services completely disrupted. But some of the good news we found is that countries start to prioritize and put on the policy agenda mental health. 89% reported that mental health is part of their COVID response plan. 2/3 of the countries has established multi-sectoral mental health and psychosocial support coordination platform during the COVID-19. Out of 130 countries responding, 2/3 of them said they have this coordination platform. This coordination platform would include education, social sector, health sector, and others. But the bad news here is that 17% of countries only reported that they have allocated full resources to implement the plans they have for mental health as part of the COVID response. Next, please. And at global level, United Nations agencies and international NGOs has put mental health really at the top of the COVID-19 response. WHO Executive Board, which is WHO governing body, has actually had a decision by all the WHO member states, approved by all of them, on making mental health an integral and cross-cutting component of all public health emergencies response. The United Nations Secretary General has issued for the first time a policy brief with key recommendation for all countries, for all states, on having a whole of government approach to address mental health as part of COVID-19. For the first time, the humanitarian response plan, the GHRP, have COVID-19 as a cross-cutting issue integrated. Decisions from the UN General Assembly. WHO included mental health as part of essential healthcare services packages, and a joint interagency call for actions from the head of OCHA, the head of UNHCR, the head of IOM, the head of UNFPA, UNICEF, and WHO, calling for increasing and scaling up mental health support. It became very high on the policy agenda. Next, please. And within humanitarian settings, and we know the impact of COVID-19 has been really devastating in these situations, WHO, as I said, could share together with the Red Cross movement, IFRC, across an interagency mental health and psychosocial group, the ISC MHPSS reference group, which was responding to this emergency very early since January, and released wide range of documents that I have shared with you here in the links I shared in the chat function, and I hope Gunjan will share also after this call. In fact, in humanitarian settings, 1 in 5 would have a mental health disorder. colleagues, the number of country-level mental health and psychosocial technical working group coordination platforms in humanitarian settings has increased like 2 times, from 22 countries to 50 countries in between during last year, showing commitment from humanitarian actors for mental health and psychosocial support coordination, as well as WHO started launching a rapid deployment mechanism of expertise in mental health and psychosocial coordination. In fact, these are 2 pictures of the 17 coordinator we deployed to 17 different humanitarian emergencies to coordinate mental health and psychosocial support last year, and we did the same so far this year. We are in March. We did the same with around eight deployed coordinators. Next, please. We released wide range of resources across the life course. One of them, where we really engaged with communities all around the world, we released in April last year, 1 year ago. 1 year ago, we sent a survey to ask children, parents, and teachers during the first lockdown to ask them how they are coping and how COVID-19 is affecting the mental health well-being of children. We got responses in the first week. 1 year ago, we got responses from 100 countries, 1,700 children, parents, and their caregivers. And based on this content, we did not only develop messages, but actually develop a children's storybook. This children's storybook became very popular when it was released. Now it is currently available in, you will see it on the link I shared, in 137 different languages, including indigenous languages, local languages from all around. We only translated it to 6, but communities around the world has taken it, adapted it. You will find the Zimbabwean Blind Women Trust, for example, adapted it in Braille version. It is available in sign languages in at least 4 or 5 languages. You will find it on the link I just shared. It is also available in easy to reach version for children with disabilities in numerous languages from Africa to Latin America. Another resource is Doing What Matters in Times of Stress. This is for adults. All of us need to cope with stressors during COVID-19. And based on acceptance and commitment therapy, this Doing What Matters in Times of Stress is an illustrated guide that will teach you a set of skills so that you can cope with day-to-day stressors, including in situations such as in COVID-19. It's evidence-based. So based on randomized controlled trials, we know that doing what matters in times of stress can actually help people in self-help and reduce stress symptomatology. I'll talk then about the last resource here, which is actually one of those most recently released, is the Mental Health and Psychosocial Support Toolkit for Older Adults, a group which unfortunately classically neglected by mental health interventions, but we wanted to develop an intervention with them. And we followed the idea of Where's Wally, a simple theme that many of this age group would know, to develop and adapt some key messages for mental health and psychosocial well-being for this age group. If you want to download any of these resources, access the links I just shared with you. Next, please. There are also online platforms with numerous case studies on how people were adapting services for mental, neurological, and substance use and mental health and psychosocial well-being during this pandemic. Next, please. One of the resources which I'm putting here is basic psychosocial skills. It's not only health workers or social care workers who need to learn basic psychosocial skills. It's everyone. We knew this from the beginning. People at points of entry, at airports and ports, people who work in food distribution, people who work in law enforcement, people who work in grocery stores, everyone who are part of the essential response to COVID-19 need and can contribute through a set of very basic psychosocial skills. So we developed, for a wide range of educational backgrounds, a comics book, which gives people specific and messages on how they can care of the well-being of one another. Another very nice resource here you'll see is operational consideration on adapting multi-sectoral mental health and psychosocial support program during COVID-19 pandemic for education actors, social actor, camp management and coordination, how people can adapt for different age groups their mental health and psychosocial program during this pandemic, available in, I think, around 7 or 8 languages now. And the interim briefing note, which include specific key recommendations that we will address as part of our exercise today. Again, available in around 20 languages online on the link we just shared, and thanks, Anne, for sharing it. Next, please. Colleagues, I think I'm running out of time, so I'm not going to go through these recommendations in details, but these are basically the key recommendations from the UN Secretary General Policy Brief and from the Executive Board decision. First, applying a whole of society approach to promote and protect care for mental health. Next slide, please. Third, ensure widespread availability of emergency mental health and psychosocial support. Next. Support recovery from COVID-19 by using this emergency as an opportunity to build better mental health care services for the future. Last slide, please. So we recently released as an accompanying guide for the children's storybook, and thanks for the colleague asking about the use of these resources. We are releasing a catalog about how this resource was used by different communities all around the world. It's important to share that in all these languages, it was actually translated by communities, by governments, by universities, by agencies on the ground to use it. So we reached back to them 1 year after and asked them how they used it. And we released the catalog. And I'm going also to share with you a nice short documentary in how this children book was used in different communities. So we released recently an accompanying book for teachers and for parents on using this to read with children while reading this guide called Actions for Heroes. And the name reflects what's included there. Actions that children and parents and teachers can do while reading the book, and also there is the disaster risk reduction linked to MHPCS. How can we prepare? We're talking a lot now about response, but there is an important component which is about preparedness, which is included in this nice, colorful first guide here on disaster risk reduction. And finally, the very newly released Older Adults Toolkit, which is currently ongoing translation in numerous languages, but currently available only in English, but just released. Colleagues, thank you very much.
Thank you so much, Dr. Fahmy, and for sharing the resources and for giving us an overall picture. I'm sure people have a lot of questions. Please put in any questions that you have. Also, any feedback, any comments, your own experiences into the chat box. But for now, I'm going to move to our next speaker, Dr. Emma Chademana. She is head of programs for One-to-One Africa, and she supports teams to provide essential maternal, child, and adolescent health services in rural and impoverished communities in South Africa. Emma, I know your team has been working on mental health even prior to the pandemic. So if you could share with us some of the issues and concerns that you have been seeing in the field, what is happening, that would be great.
Great. Thank you, Gunjan. Good afternoon or evening, everyone. I'll just give a brief I'll share briefly our experiences and what we have seen in the field. So just a very quick background to it. One-to-One Africa is a maternal, child, and adolescent health organization. So we support, we train community women to become what we call community health workers or mentor mothers, and they provide door-to-door healthcare services in the rural. Our programs are mostly in the rural communities. Our largest program is in the rural Eastern Cape in South Africa. So as I said, we're working with community health workers. So as you know, this cadre of health workers are frontline workers. They're providing healthcare at the household level. So unlike other health workers who can limit their support to health and social services only, they also provide support with other issues. You know, when they get to a household, there's issues such as gender-based violence, there's substance abuse, extreme poverty. So they're faced with a lot of issues that they end up having to address and work with clients. So before COVID-19, mental health was always a concern for us, for this, these frontline workers. So then COVID-19 came along. It brought its own set of challenges and mental health issues. So our community health workers were faced with several challenges at the onset of COVID-19, where we resorted as an organization in level 5, when there was lockdown, we resorted to a telehealth approach where they were providing services to their beneficiaries, our project beneficiaries, who we call clients. So they were working from home, doing remote phone calls and trying to support them and doing hospital referrals. Unfortunately, working from home was not easy for them. So most of them live in large households, as you may imagine, in the rural areas, with extended family, and also their partners had returned home after being retrenched as a result of the pandemic. So they had no personal time, they had no space, and when they returned to work, it was really difficult. They also experienced other challenges. So, which I will explain as I go. So to better understand how COVID-19 had affected them, in particularly their mental health and well-being, after hearing their concerns and the issues they were experiencing, we conducted a psychosocial well-being assessment using a validated tool that is part of our mHealth application, our mobile health application. So some of the concerns that came out of the psychosocial well-being assessment include fear of the pandemic and fear of losing loved ones, anxiety about a lot of issues, firstly, not knowing when vaccines would be available, children being out of school, anxiety about not being able to support their patients and how their patients would be able to get a restock of their medication when everything is closed, because there was a time when health facilities were actually turning people away. So this also brought about a lot of stress on our community health workers. They were also concerned about how the community would view them and whether they would be able to do their job as effectively as they did before. So some community workers were actually turned away when we returned into the field. They were turned away from homes and by the community because everybody was fearing COVID-19. Nobody wanted to have people who are not family members in the homes. So this also brought additional stress because our community workers then internalized this, and they also now started fearing, those same fears that the community had. They started fearing that maybe we would bring COVID-19 to our clients because they move from house to house. So they were now worried that they would transmit the virus in that way. And then they were also worried that they would in turn also transmit the virus to their families and bring that back to their families. So that caused a lot of anxiety and stress and worry. So as a next step, after we assessed this information, the psychosocial well-being assessment data, we then engaged a social worker. We got funding from the DG Murray Trust to provide psychosocial support in intervention. So we engaged a social worker who then provided a series of group sessions to unpack some of these concerns and provide some psychosocial coping skills, some of which Femi alluded to, those skills. Also things like self-care, mindfulness, being aware, and when you need to seek help and when what to do, what are the steps you take, when you're experiencing extreme depression or any form of depression or worry. So, and then in addition to those group sessions, then some of our care workers then are now receiving one-on-one support, counseling and support sessions, depending for a whole broad range of issues that they were experiencing. And then lastly, we also have been encouraging them to make use of our wellness program that has a 24/7 counseling support line. So it's over the phone, and then there's also one-on-one sessions as well. So in a nutshell, those are the interventions that we've managed to provide our community health workers.
Thank you so much, Emma. And now I am going to hand it over to my colleague, Nelly, to take us through this discussion.
Thank you, Gunjan, and thank you to both Emma and Fami for those very comprehensive presentations with so much information. I think, you know, one of the things that we were discovering on our previous call and is coming through so clearly is how, you know, mental health issues is so often overlooked, as Fami was saying, so underfunded, but as you've both made clear, it's very common. It affects so many of us, and it's really at the heart of a lot of the community-led work that we're all participating in. We're going to open it up for discussions, and I see already in the chat box there's reflections happening, questions, thoughts. Before I do that, though, I just wanted to return, Fami, to you for a moment. And Emma's just raised a number of really important ways in which mental health, and specifically with the COVID pandemic, things that community health workers in particular are facing. And I was wondering if the IASC has looked at that specifically, or if there are resources that are directed to community health workers. And there may not be. I mean, there's so many different groups that are facing both unique and common issues. Or any other reflections on Emma's presentation. So Fami, quickly over to you.
Nelly, thank you so much. I think this is an excellent question. All frontline essential workers have encountered severe and impactful stressors during this pandemic, because they suffer from workload, the change of their working style, the increase in demand. At the same time, they are worried about their own physical health. They worried of getting infected or infecting loved ones. So all frontline workers have been really affected, and from community workers to community health workers to colleagues who work on social sectors to volunteers. One of the tools I shared today is the basic psychosocial skills for COVID responders, and this is indeed one of the tools that I would recommend to all community workers to have a look at, to read and practice the set of skills which are in there. This is not a psychological intervention. This is not teaching you to do counseling. This is basically the basic psychosocial skills: how to talk and take care of someone in respecting their dignity, in taking care of their well-being while you communicate with them, and providing them with practical, immediate support in dignified way. So it's basically teaching you this, what we considered as basic psychosocial skills. This is the equivalent of many of you know as psychological first aid. We all know that physical first aid is not treatment. This is psychological first aid. This is the basic essentials that every human being need to provide to fellow human beings. So basic psychosocial skills is key, but there are more advanced skills. In WHO, we have a program called Image Gap. We know there is a gap in mental health services, so we develop packages to address this gap. And one of the key groups that should address these gaps is actually community workers. So we developed a toolkit for community workers on addressing the mental health gap. I'm going to share now with you the link. Another message we have in the basic psychosocial skill document is, if you're going to address the well-being of the population, it's very difficult for you to do so if you don't address your own well-being. You don't take care of your day-to-day own mental health. You take a break, you promote positive coping, you avoid negative coping mechanisms such as smoking, alcohol, or drugs. You do things that we would usually do that would help you feel relaxed. Some people would go for a walk, some people would pray, some people would talk to loved one and seek help when you feel that you need help and support. There's nothing stigmatizing about this. But you can use tools also for self-help, like the stress management guides that I just shared. So so there are tools that can help community workers, and just now I'm going to share a couple of additional links. Thank you.
Thank you so much, Fahmi. And I just want to echo your point about our own self-care. That was something that came out of the last call also, was how both to support our community partners, but also our colleagues and staff within our own organizations and ourselves from that added pressure. And I've seen a number of comments in the chat about how to access these resources. Fahmi's been putting many of them into the chat box, and we will also make sure to collate them and share them when we send the summary for this call. So there's a couple of questions coming into the chat box, so that I wanted to point to them. One is from Liana. It's for Emma. Would you like to ask that question yourself?
Sure. Emma, I was just curious if you could please talk more about the assessment you did, and is that a tool that you would recommend? Is it available to others in paper form or as the app? Thank you.
Sure. Sure, Liana. Yes, it is a tool developed by the University of KwaZulu-Natal here in South Africa. My colleague Renee Diane, who is the impact manager at One-to-One, was leading with this assessment. She can speak more to this tool.
Renee, I think you have to, yeah.
Okay, great. Thanks, Emma. Thanks for your question. So we developed this psychosocial well-being tool for community caregivers because, as we all know, in community caregiving, there's a broader spectrum, as we know, of caregivers at different levels with different sets of skills. And so we worked together with the Department of Social Development in South Africa at that time to really look at what were the stresses, what were the issues that community caregivers were facing at the time. And so the psychosocial wellbeing tool was mainly developed with 2 subscales, looking at, so the items, it's a 30-item scale, looking at well-being, and then also stress, compassion, fatigue, and burnout. And so, yeah, we administer the tool as a pre and post assessment and analyze, the data and what the community caregivers were saying in terms of where do they go to for help when they are stressed. Within the organization, who is it that they lean on? How supported do they feel within their organizations? And in terms of, what tools are they using? I think Fahmi touched on this. What tools are you using to cope with stress? And what kinds of outlets are you using in order to deal with stress? So we found the data to be very interesting at that point, and we felt that at the moment on our for our community health workers in the Eastern Cape, which is more a rural environment, administering the tool and looking at what the results were saying would be an interesting finding. So we have preliminary results at the moment. We're looking forward to reading a full comprehensive report with regards to the data. So as Emma mentioned, the evaluation or the assessment of the psychosocial well-being of our community caregivers are quite paramount. It's important, I think, for us as a organization to not only assess, but also to see what we can do in order to address the mental health and the issues that our community caregivers are facing. We also added 14 items, questions to the tool that are specifically related to COVID. So we asked them questions around not just, you know, I think we started off with demographics, but then went on to the 30-item assessment of the psychosocial wellbeing tool, and then questions related to COVID. So it was quite a comprehensive tool, and it took between 30 to 40 minutes for the, you know, the recipients to answer the questions, and we were then able to, you know, have a cross-section of supervisors plus our community caregivers participate.
Thank you, Renee. Thank you. And I also wanted to highlight a couple of people in the chat box have been also raising some other organizations that are working on mental health, including Dan was noting the Shanta Foundation and Rihanna work that's happening in Zimbabwe. And one thing is just if anybody wants to ask a question or share a reflection, as mentioned, you can do it in the chat, but you can also raise your hand, and I'll rely on my colleagues to tell me if there's any hand raised. Also, Mate, and apologies if I'm mispronouncing your name, but I saw that you put into the chat the work that Wilmot Development Foundation Uganda is doing, and I wanted to see if you wanted to quickly share, because you said that you've been providing firsthand information, mental health awareness within the structures that you already have in communities. Maybe you could tell us a little bit about what that looks like and how communities have been using them, what the uptake has been. If so, please feel free to unmute yourself. I see you, but you're not unmuting, which is fine. People can look in the chat box and we can look it all up. So let me know if there are any other questions, but in the meantime, Fami, you mentioned how it's very important to be paying attention to self-care, to the mental health of members of one's organizations. Do you know of any organizations that are really sort of modeling this in a great way? Oh, and also
many organizations are starting to pay attention to this area of work. For example, within WHO, in addition to having counselors for staff, we start to have a focal point for looking at mental health at workplace and developing WHO guidance on mental health at workplace in collaboration with organizations and expertise in that area, such as ILO, the International Labour Organization. We also within the ISC developing technical guidance note, specifically for local NGOs in humanitarian settings, focusing on mental health and psychosocial well-being of humanitarian staff working within local NGOs. And Nelly, this would be really a key document, I think, to add to the agenda, to the conversation we are having this month with the movement on possibly contribution from your side and from community-based organizations around the world to this document, because this document is targeting specifically this group. We all put it on the agenda. ISC principles, heads of UN agencies and the international NGOs has one of the recommendations clearly in the joint interagency call for action for addressing the mental health and psychosocial well-being of staff. There are international organizations which are specifically dedicating all their work on this. One of them is the Dutch-based Antares Foundation, for example. Antares Foundation is an international NGO which is specialized in providing mental health support to frontliners. Big humanitarian agencies like MSF, Doctors Without Borders, are well known to have mental health and psychosocial support for every person deployed in the field, provided free of charge. For us within WHO and also within IFRC, all the rapid deployment I mentioned, part of the support package we provided to people who got the rapid deployment is access to mental health support. It's important to mention that that mental health and psychosocial well-being at workplace is not only the issue for the person responding. It's also a workplace culture that need to be there. That's why in the guidance on mental health at workplace, there are always recommendations to address to the managers for taking care of their well-being, exactly like teachers. If you cannot make sure that children at school are having their well-being at school in classroom going well, unless you make sure that the teacher in classroom is also having good mental health and well-being. The same for the manager would apply. That's why in the interim briefing note I shared with you, there are specific recommendations going to workplace managers actually.
Yeah, exactly. And we will, I know Gunjan and others from the movement will definitely be following up with you and then reaching out to the group to precisely add this to the agenda for a specific call on it. Of course, now great questions are coming in and comments as we're about to have to move. I wanted to raise Dr. Rebecca's point about working with spiritual leaders or religious leaders on spiritual teachings and how that can be an important part of mental health. And then Anne came in and talked also about the ways that in different parts of the world, people feel more or less comfortable with those topics and how to integrate them, which I think is really an important element to this. I see that Ernie has his hand raised. Is there anything you'd like to share or ask? If so, you can just unmute yourself. Yeah.
Yes, thank you very much. Yeah, I work for Mercy Corps in Nigeria, so and I'm very happy to be part of this call. I want to say that in my community, mental health is nearly a taboo topic. It's not something that people talk about, openly. Even those who are at risk of mental breakdown would rather stay in denial than seek help. And I dare to say even professionals, who work at the community level, even at peri-urban, areas, find mental health and seeking help as something near shameful. And therefore, people live with the dangers, of, the issues associated with mental health rather, instead of seeking help. So I just want to find out, is there or is it not possible to develop a set of, tools that would make it easier to encourage people at the community level to seek help, especially those who are at risk, of, mental breakdown? As a matter of fact, it is clear knowledge, that there is so much stigma attached to, mental health or mental health related issues in rural or even urban communities in developing societies. So are we looking at some set of tools, that we can use to encourage people to be more open about issues associated with mental health? Because it might be easier for those of us who are more enlightened, better opportune to seek help. But there are people who have also been, being negatively impacted by COVID and other issues that are happening in Nigeria. For example, I work in Borno State, and of course, you know that in Northeast Nigeria, the conflict there, plus COVID-19 has actually ravaged people mentally. And as a matter of fact, there's nearly no help available, whether officially or unofficially, for people to get help. And I would be very happy to know if there is a way that we can make mental health issues and seeking help more acceptable, more palatable, more desirable for people at the community level.
Thank you, Ernie.
Especially. Thank you.
Thank you, Ernie. And I just wanted to, Deanna had a similar question in the chat box that was precisely about how to overcome stigmas. Arthur, I see that you have your hand raised. If you don't mind putting your question just into the chat box so we make sure that it can be answered even if we don't have time. I also see that Anima put a question in there, but quickly on the point of stigma, because that's such an important issue, over to both Fahmi and Emma briefly on that.
Ernie, I think it's a brilliant point, and let me also tell you that in mental health issues, outside of emergencies and outside of situation like this, like the pandemic, it's not only about increasing the supply, it's also about increasing the demand. I remember many years ago, there was an excellent project in one of the states in Ethiopia, one of the areas in Ethiopia. And that project really done a very good job in introducing mental health services into a community where mental health was never provided before. And brilliant intervention, and aimed to provide coverage to more than 75% of the population. But when colleagues who were doing some of the best academics really in the world, when they were looking 1 year later, they found that people who were accessing the available service were really like 10% of what they originally expected. The key issue here is that they looked on increasing the supply at that time without working on increasing the demand by first letting the community know that a new service is becoming available. If people do not know that service for depression or for psychosis are now available, for example, at primary health care for the first time, how they would come? They don't know. How they would know that the service they have is a mental health condition unless we explain to people in culturally adapted way. You know what is the best evidence available for an anti-stigma intervention? It's actually by making sure that communities are having people with lived experience talking about their needs to the community. Because this whole motto that WHO has raised for, and many agencies raised for a long time, nothing about us without us, is actually evidence-based. We cannot talk about people with severe or common mental health conditions without actually involving them. And we have evidence that using this intervention actually reduce stigma. You can also adapt culture and awareness raising materials, including information sharing, but the key way is engage people with lived experience and not always only think about increasing the supply of service, but also about increasing its demand. Specifically in Borno State and in Maiduguri in northeast Nigeria, some of the links I have shared are actually having materials available in Hausa and many other local languages, at least 3 other local languages from Borno State. So I encourage you to browse through these links, and happy also to have a bilateral communication with you, to share with you the emails of colleagues who are active in Northeast Nigeria and who developed this material, adapted it for local context, and also can share with you what's happening on mental health and psychosocial support there. Thank you.
Thank you. Emma, is there anything you'd like to raise? I saw in the chat you mentioned also that it's particularly difficult with men sometimes to discuss mental health issues.
Yeah, okay, just a quick comment. Yes, what Ernie did raise is we see that as well in our communities, in rural African communities. It also goes back to culture, and I see somebody did mention culture as well. And then I was just typing a response to Amina as well. She had also asked about what other methods and activities people can do. I think something else that we don't always are conscious of is having a support system in place. And support system doesn't mean you have a problem, but you always just need to have a support system, a good support system in place. It also helps to support you and also to talk about whatever issues and concerns. Is just something that's easy and simple that people should also be mindful of. Thanks.
Thank you, Emma. So we are about to move into our breakout groups. They're normally 30 minutes. This time we'll have about 20 minutes. And we, as always, are going to discuss and take notes and use an Excel sheet to help guide our discussion. But we're going to base our conversation off of a set of recommended activities that Fahmi's introduced. So Fahmi, I was wondering if you could just introduce this document and these activities to us in just about 1 minute. And I apologize in advance if I cut you off or give you a 10-second warning to to finish that. But if you'd like to, yeah, explain to us.
Sure. In 1 minute, Nelly, these are 10 recommended activities which was developed by the Interagency Standing Committee early in this response for what mental health and psychosocial support activities are considered gold standards. They are included in the interim briefing note, which is available in so many languages that I shared with you. But the aim of the exercise, go through these 10 activities and think how you can adapt for your context. Think what are concrete activities you can do in your own countries adapting these recommended activities.
Perfect, even less than a minute. So yes, we will move into our breakout groups. There will be 3 groups. Sarah will direct us all to them. We will have a facilitator and someone taking notes in each one. And based on using these as a guide or as a background, these particular activities, we'll think about, what are some of the mental health issues that have surfaced during COVID, either were already there or are new. What's being done in your organization or the communities you work with to address them? What are some of the activities, again, with this as a resource to look at that could be adopted to address mental health issues? And then what else do we need? What do we not have in order to effectively work on this? As always, once we return, we will ask each group to share 1 or 2 key takeaways. So please identify someone to share out, and remember to record the session. So with that, Sarah, do you mind moving us over?
Sure.
Thank you. Welcome back. I know in our group we got cut off, unfortunately, so sorry to Dr. Saidu for that. I think there's still a few people that will be returning, but we don't have much time, so we wanted to make sure that each group could share back to the larger group. So I first wanted to hand it over to someone from group 1. If you'd like to share. Has group 1 identified someone?
Yeah, we have Kathy who's going to share. Kathy? And I will just share
Hello.
my screen.
Hello.
Yeah, go ahead. We can hear you.
Okay, thank you so much. This was group 1. We had a lot of discussions from different people from different places. We had from South Africa, Malawi, Nigeria, Uganda. And some of the key things that were shared, as you can see on the screen, there was a lot on community work, not being able to reach patients, and a lot of frustrations that really came in. And then in that triggered, the team from South Africa shared with us that they were able to develop different COVID-19 protocols, which included providing PPEs to ensure precautions are being taken care of and not to go into people's homes. Around education, there was a lot on uncertainties, and for me this was really a very catch area because I work in education as well. And this was sharing from our colleague from Malawi, who shared that there was a lot of uncertainties in school reopening and then protection for teachers. But then they were able to come up with solutions that helped, like working with the students and teachers in clusters, in small group learnings, that helped to keep learners and students still studying in smaller groups. The other main key point that was also shared was about partnerships with other people to provide funding to continue with the learnings. We also shared about doing stress with basic services to enable schools not to stop working. Then the other take from Dr. Fanny, who also shared with us that it's really important when we are doing mental health, it shouldn't be done from one sector alone, but something that should be done in an intersectoral cross-cutting manner. And he also shared with us that even amid this pandemic, a lot of opportunities have been able to come up in regard of mental health, and a lot of awareness has been created as well.
Thank you,
a team
Kathy.
from AVSI where I work as well, partnerships.
Great, thank you so much,
Yeah.
Kathy. From group 2, I believe we have Deanna.
Yeah, let me just share my screen. We had a lot of notes and people participating in the chat box. Thank you for that. I think that what we have as maybe key takeaways, and if someone wants to jump in, of course, but on one hand, what we have is what we are living in communities and in our work in field, and how to start breaking stigma with people who got sick, and also people who people having this stigma around mental health on one hand, but at the same time, it's what we live in our daily life with working from home and having this fear about losing jobs or working more. Of course, burnout is something that it's happening. So it's a combination of how to help people outside our lives and also with what we are doing with our own activities daily. And most of the organizations that most of the people in the group are related to what the organizations have done. It's like they are having a counseling service for staff, like Mercy Corps was one of the examples, but at the same time also how to being flexible as possible and try to have close contact with the team members and give as much as information as needed. And also the religious institutions, it's something that came into our group, I think. And related to the activities that the organizations are doing, it's like having specific trainings to incorporate the counseling for staff as something even stronger with these times. And I think that, yeah, to use the resources that many organizations are having and some others that we're knowing, because all this mental health issue is getting more attention, and we're there are some other resources available, so that might be something. And I think that could be it. If someone wants to jump in, of course.
Thank you, Deanna, that was great. And if there's anything else from any of the groups, just put them in the chat box. And then is there anyone from group 3 who would like to share? And I believe
I know we're tight on time, so I'm just going to go ahead and share. One thing that we did come up a lot is anxiety around the vaccine itself, and that was just one of those issues where it seems like on the one hand you think you're not a mental health professional and you may even know very little bit about the topic. So what could you possibly do? But I think one thing I'm really taking away from this call is that you can just start to bring up the topic in the context of your organization and your community. And you can go from there together, and that there are a lot of relatively simple ways to get started. Thank you, Fahmi, for that. And there's a lot of available resources. So even just Teddy gave the example of people who've lost their jobs and are depressed and maybe turning to crime. What if there was a support group or a way for them to come together and just even to be together? I think even support groups where people can start to talk and think about what to do can make a big difference. And also to start to address the stigma issue as well. So I kind of feel empowered for all of us to be able to just bring up the topic and then start to download some of these resources and contact people on this call and move forward. And I also want to say one other thing. I do think there's going to be a fair amount of PTSD after COVID, because people are kind of like holding it together during COVID. But then when it's over, it's like all of that holding it together can sometimes then turn into PTSD. So it's something we'll probably have to talk about later. But again, a lot is known about PTSD, and I think there's a lot that people can do. So I will stop there.
Thanks, Anne. And I see there's more things coming in the chat box, and we'll be sure to integrate all of this into the notes that come out of this and the Excels. And with that, I will hand it over to Gunjan to close us out for the day. But thank you, everyone, for a great discussion.
Okay. Thank you, everyone, for a wonderful discussion. I know there were a lot of points. I know in our group, we didn't finish our discussions. This is a topic, I think, which we have just scratched the surface of. We may need to come back to it time and again. And I hope with the communications, with the contact that we are able to establish with WHO and other agencies, we will be able to, continue to do so and continue to look at resources and other examples and case studies that we have. I just wanted to close out by saying, by kind of going back to what I started with. It's been a year of this journey, and what we have done is that, a lot of you contributed to this. We reached out to you to ask you, what has this 1 year been like? What have been some of your key takeaways? What have you heard? What have you learned? What questions still remain? What changes have you seen in your organizations? On our website, we have actually curated all of this material. I've just shown a few postcards here, but please do look at it. It's really interesting to see what people's takeaways have been or what have been the key changes. So there's some really interesting material there. I do want to, just before we close out, first, I do want to thank both Emma and Fahmi for the wonderful discussion, for sharing the resources. I want to thank everybody who's been on this call for sharing. A lot of organizations brought up some really important points, but I think all of it points to something that Fahmi said in our group, which is that emergencies do present opportunities for change. And I know we had Nibat and other colleagues sharing how the pandemic became a way for them to start thinking about mental health, which they hadn't done before. So thank you everyone for the discussion. On the screen, you will see a few quick event reminders that we as the movement are doing. On the 21st of April, 9 a.m. India time, 8:30 a.m. Pakistan time, 10:30 a.m. Indonesia time, we have our Asia call, where we have two wonderful stories. We have PECA Indonesia, which for those of you who don't know, is a remarkable story of how something which was supposed to be a small woman's component, it was called the Widows Program when it started out, of a big World Bank program, became an entire movement that transformed the lives of single women, women-headed households across the country, and changed the way that their place and position in society. It is a remarkable story. We have PECA Indonesia, and we will have the National Solidarity Program Afghanistan being discussed. We'll have our regular CLD monthly call. I'm sorry, I noticed that 28th is missing, but on April 28th, we will have our regular monthly CLD call. And then on the 19th of May, we have an independent dialogue on mobilizing resilient community-led food systems. This is for the World Food Systems Summit. We want to make sure that we are able to input into it the need for community-led food systems. So you please join us for these calls as and when you're able to, depending on your area of interest. You can find information about the calls in our mailing lists. If you're part of it, you will receive them. And finally, we have a food systems advocacy team that is being created. If you want to be a part of that team, if this is something that you're really passionate about or working in, then please let me know. As always, for the COVID calls, we will have our next COVID call in May, date to be announced. But please write in if there are issues you would like us to take. Please write in if there is something specific you think we should be focusing on. And we will share the call recordings and resources. So with that, I am going to end the call. As usual, we'll hang back for 5-10 minutes for anyone who wants to share comments. And thank you.